You're listening to the Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bench to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast. Hello, and welcome to the Oncology Nursing Podcast. I'm your host, Stephanie Jardine, Oncology Clinical Specialist at ONS, and today we're talking with Reanne Booker, nurse practitioner at Foothills Medical Centre in Calgary, Alberta, about how radiation is used in palliative and end-of-life care and its nursing considerations. Reanne is presenting on the topic at the 47th Annual ONS Congress in Anaheim, California on April 30th. You can also earn free NCPD contact hours after listening to this episode and completing the evaluation we've linked in the episode notes. Thanks for joining me today, Reanne.
Well, thanks so much for having me.
So to start us off, let's discuss radiation therapy and its mechanisms of action.
So radiation therapy is frequently used to help alleviate cancer symptoms. Approximately 50% of all prescribed radiation therapy is with palliative intent. The goals of palliative intent radiation therapy are to alleviate symptoms, help preserve function, and maintain or improve quality of life. And so it's important to consider that the therapeutic effects of radiation therapy are not immediate. It can take anywhere between 1 to 4 weeks for patients to derive full benefit from the treatment. This means that it's really important to think about how much time the person might have and if they might die before the treatment provides benefit. Of course, it's impossible to know with any degree of certainty how much time someone may have, but in general, if the patient is not expected to live at least several weeks, palliative radiation may not be the best option.
In thinking about that, when would you say radiation might be a viable option to help alleviate cancer symptoms?
Yeah, I think anytime there's symptoms that might respond to radiation therapy, and so that, it could be symptoms related to the primary tumor, or there could be symptoms related to metastatic disease. Again, that might be a situation where radiation therapy might be beneficial, but we want to think about the benefits and potential risks associated with radiation therapy and really weigh that carefully. In the palliative context, and again, this is not exclusively related to end-of-life care, but if the intent is to palliate or alleviate symptoms and improve quality of life, it's really important to weigh those risks and benefits for patients.
So a lot of our listeners might be nurses new to oncology or just out of school, or even just moving into oncology from a different discipline. Can you talk a little bit about how palliative radiation therapy is different from other radiation therapy approaches?
Yeah, I think that's a great question. So one of the biggest differences is really that intent or the goal of the treatment. And palliative intent radiation therapy is meant to alleviate symptoms rather than to cure the disease. Although palliative care, including palliative radiation therapy, can still be delivered concurrently with curative intent treatment. But when a treatment's given with palliative intent, whether that's RT, radiation therapy, or some other treatment, it's really important to discuss the anticipated risks and benefits of the treatment with patients. So what is the expected benefit of the treatment, and what are the possible side effects and risks? If the intent is to alleviate symptoms, but not necessarily cure the disease, it's really important to consider the side effects of radiation therapy and the overall impact on day-to-day life for the patients and their family caregivers. For example, will the treatment require significant travel to and from the cancer center? And how will that impact the patient and their family and loved ones? And so that might be different for somebody if cure is the goal. They might really be willing to put up with a lot more discomfort associated with treatment or invasiveness or impact on their day-to-day life. But if the intent is meant to provide symptom relief, then we really have to think about the other things, the trade-offs, so to speak, that the person would have to face if we're going to provide palliative intent treatment.
Thank you. I think that's really a good thing for people to understand when you are talking about palliative care, end-of-life care, those goals, and how to talk to our patients about that. So talking about patients, what patient population would typically receive palliative radiation therapy?
So radiation therapy can be used to help with symptoms associated with primary sites of disease. So, for example, primary brain tumors. And that's where palliative radiation therapy can help to alleviate symptoms such as headaches, maybe even seizures, neurologic dysfunction. For people with head and neck tumors, palliative radiation therapy can help to reduce pain, can help to control bleeding, might help with dysphagia or difficulty swallowing, and can also help alleviate shortness of breath. And then for patients with lung tumors, palliative radiation therapy can help, again, to reduce pain, might help to relieve or reduce cough, can help to control hemoptysis, and also post-obstructive pneumonia, as well as oncologic emergencies like superior vena cava syndrome. For patients with esophageal cancer, palliative radiation therapy can also help with difficulties with swallowing. So that can be painful swallowing or even just difficulty with swallowing, bleeding, obstruction. And then for gynecological cancers, palliative radiation therapy can help with pain, can control bleeding, urinary outlet obstruction, hydronephrosis. And similarly with genitourinary cancers, palliative radiation therapy can help, again, with pain, hematuria, and also urinary outlet obstruction. For rectal cancers, palliative radiation therapy can help control bleeding, tenesmus, rectal obstruction, and also pain. And then radiation therapy can also help alleviate symptoms associated with metastatic sites of disease. So here we think about things like bone metastases, where palliative radiation therapy can really help to reduce pain and alleviate other oncologic emergencies such as spinal cord compression. Skin and subcutaneous tissues, sometimes there's bleeding or even fungating tumors, and palliative radiation therapy can really help to control the bleeding and pain associated with those situations. So really there are very many situations or patient populations that could derive benefit from palliative radiation therapy.
Yes, there are so many areas that you mentioned that can definitely benefit from that. So, do you think that palliative radiation is an underused treatment for patients who are experiencing these different symptoms?
I do. And I think, it probably varies depending on which cancer center you're at. And it's probably variable, between Canada and the US for a variety of different reasons. But I think overall, palliative radiation therapy is underused. And one of the biggest reasons I think that it's underused is that there's still significant misperceptions about what palliative care is in general. And these misperceptions are not only harbored by patients and family caregivers, but also by clinicians. And for clinicians, there can be reluctance to refer patients for palliative care of any kind because they worry about eroding patient hope or causing undue stress or worry for the patient. But there are also lots of healthcare system related factors as well. And this relates to things like lack of access to or availability of radiation services. Facilities that provide radiation therapy tend to be located in major urban centers. So this can pose challenging for patients who reside in rural and remote areas. And if we think more broadly, access to radiation therapy globally is still a major challenge. According to the Union for International Cancer Control, 80% of the world's patients with cancer are in low and middle income countries, yet these patients have access to only 5% of global radiation therapy resources. And there can also be lots of patient-related factors as to why palliative radiation therapy is underused. There can be practical challenges, such as getting to and from the cancer center. Additionally, patients need to be able to provide informed consent for treatment. So if capacity is an issue, that can be a challenge. Patients also need to be able to follow verbal commands. They need to be able to tolerate laying still on a hard-top table for about 15 minutes or so. And, I remember attending one of the treatment planning sessions for a good family friend. He had a head and neck cancer, and he couldn't tolerate laying supine for more than a few minutes. He would have such buildup of secretions, and it would make him feel as if he was choking. And so part of my role as family friend, but also I had my oncology nursing hat on a little bit too, was to advocate for him to have frequent breaks so that he could sit up and clear the secretions. Unfortunately, they didn't have any suctioning equipment in the room. And so it was really challenging for him to go through even just that planning session.
So, with your example of your family friend and how palliative radiation could help him, as well as trying to figure out what the best, method for doing that, because as you said, he wasn't able to tolerate lying flat. So, in thinking about that, do you feel that palliative radiation has an impact on patient care and outcomes.
Yeah, for sure. And again, thinking about him specifically, his situation, he knew that the tumor he had, the cancer he had, was not curable. And so again, we really had to look at the benefits and potential risks associated with the treatment plan. And so in his situation, the palliative radiation was, the intent was to reduce some of the symptoms associated with the tumor, help him to be able to swallow better, have less painful swallowing, and those kinds of things. But, during the planning session, we were really having to weigh those risks and benefits and think about, is this really going to provide him with optimal or significant symptom relief? Or are there other strategies that might be better, particularly if he's not going to be able to tolerate the radiation therapy treatments? But it really depends on the type of tumor, the type of cancer, and the indication for the palliative radiation. And so pain from bone metastases, patients can really derive significant benefit from palliative radiation for that. So, upwards of 60 to 80% of patients will get at least partial relief from the pain associated with bone metastases with a course of palliative radiation therapy. Something like spinal cord compression, where the patient may have profound weakness or loss of motor function. Again, response rates are pretty significant in the neighborhood of 60% or so. And things like hemoptysis or gastric bleeding or hematuria, so any kind of bleeding like that, the response rates again are in the neighborhood of 60 to 80% plus. So we do see, really good outcomes from a course of palliative radiation therapy for patients for these kinds of situations. But again, it's really weighing those risks and benefits to make sure that, that the benefit will outweigh the risk. For things like dyspnea or airway obstruction, cough, the response rates, again, they're in the neighborhood of 60 to 70%. And for brain metastases, you can see improvements in terms of someone's physical condition or their global health status overall. And the response rates can be quite significant, again, in the neighborhood of 40 to 80%, depending on the patient and their individual circumstance.
Those are some pretty significant response rates that you just mentioned. And earlier, you also mentioned how folks, whether it's patients or clinicians, maybe don't use palliative care to the fullest extent, let's say. So, and talking about it, you mentioned, patients might think that we're giving up hope when we talk about palliative care. But how can oncology nurses help patients overcome, those thoughts that we're giving up on them or something like that because we're talking to them about palliative care?
This is really a common misperception that many patients and clinicians have about palliative care. And I really think oncology nurses play a huge role in helping to combat these misperceptions, educating patients about the goals of palliative care and that it's possible to receive palliative care even when curative intent treatment is offered can be really, really helpful. Palliative care essentially offers an additional layer of support, but I think part of that perception that palliative care represents giving up stems from the use of phrases like, there's nothing more that we can do, when there are no more disease-directed treatments that could help to cure or control the cancer. But I always feel that there's always more that we can do, even if cure is no longer possible. But, we've heard in some of the studies that we've conducted where we've interviewed patients, family caregivers, and clinicians about integrating palliative care, and this is specifically in the context of blood cancers and hematopoietic stem cell transplantation, that there's a sense of abandonment that some patients and family members feel when they're referred to palliative care. And I think if we integrated palliative care earlier in the disease trajectory, some of those misperceptions, that sense of abandonment or that sense of giving up, I think we could really help to, ameliorate or diminish those perceptions. Helping to normalize palliative care as a routine part of care can be really helpful too. There was a recent article in JAMA Oncology by two Canadian palliative care physicians, Dr. Camilla Zimmerman and Dr. Jean Matthews, and they described a metaphor that might be helpful when discussing palliative care with patients and family caregivers. They compared palliative care to having an umbrella. You might not ever need it, but it sure comes in handy if you happen to find yourself in a torrential downpour. And the authors also used the metaphor to help combat that misperception that palliative care might hasten death somehow. So just like having an umbrella will not bring on the rain, referring someone to palliative care will not hasten their death. But there's so many of these misperceptions and still so much stigma that's associated with palliative care. And I think nurses are key to helping to eliminate some of those stigma and misperceptions associated with palliative care. Part of my PhD research, I conducted a qualitative study and interviewed patients and family caregivers. And the majority of participants initially talked about palliative care as being meant for end-of-life care. And they said that they would be initially perhaps, scared, or it would induce some anxiety if they heard they were being referred to palliative care. But once I provided more information about palliative care and that, we can provide it even alongside disease-directed treatments like chemotherapy and radiation therapy, most participants indicated that they'd be agreeable to having palliative care involved. And, these findings are congruent with what other researchers have found too, that misperceptions of palliative care abound, but once education is provided, many patients are accepting and even eager to consider having palliative care integrated into their care.
That's so interesting. And you're right. It does show the oncology nurse's role and the amount of influence that they have with their patients in understanding how this can be beneficial to their overall treatment plan. What would you say is the oncology nurse's role in caring for patients that are receiving palliative radiation therapy?
I think that oncology nurses are, they're ideally suited to address patients' palliative care needs, irrespective of the setting. So that could be, systemic therapy, it could be ambulatory care, it could be radiation therapy. They're absolute experts in managing symptoms and side effects and comprehensively addressing quality of life. So I think similar to their role in other contexts, listening to the patient, ensuring that treatment aligns with the patient's goals and wishes, helping to recognize and manage the side effects and toxicities associated with treatment, and advocating for the patient, including helping to reduce barriers to accessing palliative radiation therapy, are some of the things that oncology nurses can do to help patients who are receiving palliative radiation therapy.
Thanks. I think that's really important for our listeners to know and just understand. So with the things that you just talked about and that we've been talking about, how we can work with our patients to understand this better, how can oncology nurses educate their patients about palliative care and its benefits?
Well, I find that it can be really helpful to explain very briefly and avoiding a lot of jargon, but to explain to patients that many studies on the integration of palliative care and oncology have found improved outcomes for those that receive palliative care, including improved symptom management, improved quality of life for patients and family caregivers, and even improved survival in some contexts. I think nurses already do a great job with this, though I know it can be very challenging to talk about palliative care. There are different tools and resources that people can use to help frame these discussions. And one example is the Serious Illness Conversation Guide created by Ariadne Labs in Boston. And the guide provides examples of phrasing and wording to use when having these conversations, and covers topics such as illness, understanding and information preferences, prognosis, exploring goals, fears, worries, and trade-offs. So things like, what are your most important goals if your health situation worsens? What are your biggest fears and worries about the future with your health? What abilities are so critical to your life that you can't imagine living without them? And if you become sicker, how much are you willing to go through for the possibility of more time? These are just some of the examples of the wording and phrases that can be used, because it can be challenging to have these discussions, particularly if this is something that the nurse hasn't had a lot of experience or training with before.
I love those examples that you gave. I think it is so important that all nurses understand how to have those conversations with our patients, because to have them at the end, it almost sometimes seems a little bit futile. We've kind of missed that opportunity to find out what their goals and wishes are, and having those earlier on in the treatment journey or the cancer journey is so important. And with nurses being one of the most trusted professions, and that's who has more time than really anyone on the care team to spend with the patient, I think those are really good points for our listeners to think about. So some of our listeners may be nurses that are working in an outpatient clinic or on a oncology floor and not necessarily working in radiation therapy. So can you talk about what the members of that interprofessional team looks like that oncology nurses might work with when they're caring for a patient that's receiving palliative radiation?
I think it depends on the cancer center and the various different services and resources available at that particular center. But very often, oncology nurses will collaborate with radiation oncologists, radiation therapists, psychosocial clinicians, and rehab medicine specialists. And depending on the patient's circumstances, the nurse may also collaborate with specialty palliative care clinicians, including palliative care nurses and physicians and home care nurses, to name a few.
Great. So, Reanne, this has been wonderful talking to you today, and also is just making me excited for your session at Congress and to hear a lot more about this topic. So, we're coming to the end of the podcast, and there are some questions that I like to end every podcast with, and we're just going to go through those in a real quick fire manner. And the first one is, what are some common misconceptions about palliative radiation therapy?
Yeah, I think anytime the term palliative care is mentioned, many people automatically think about death and dying. As an example, in our qualitative study, one clinician said that palliative care is a service with the black business cards. So there's still that misperception, and that is, I think, part of the reason that clinicians are reluctant to refer patients to palliative care. They worry about diminishing patients' hope or causing stress and anxiety. And again, I also think there's a misperception that palliative radiation therapy or palliative care of any kind cannot be given alongside other disease-directed or even curative intent treatments. And that's just not the case. Sometimes palliative radiation therapy will be added to curative intent treatment to help alleviate symptoms. And then on the flip side, I think there can also be misperceptions held by patients that palliative intent radiation therapy is a cure for their cancer. And there have been a number of studies done where patients rate the likelihood of cure of their treatment much higher than that of their oncologists. So again, this really highlights the need to have those open and honest discussions about the intent of the treatment so that the patients have realistic expectations of their treatment.
Great. What's something about palliative radiation therapy that's not often discussed, but you wish people knew more about?
Yeah, I think I would apply this to palliative care more broadly and in general. And I wish that people knew that palliative care can be provided along disease-directed therapies and really, serves to provide that extra layer of support for patients and their loved ones. And palliative care can really help someone live as well as possible for as long as possible. And it's not the same as end of life or hospice care.
What additional training or education do oncology nurses need to care for and manage patients who are undergoing palliative radiation therapy?
I think most oncology nurses already possess the skills and expertise to help support patients during and after palliative radiation therapy. My personal bias is that all clinicians could benefit from more formal education about palliative care during their education and training programs. I think all nurses should have the basic skills and competencies to be able to provide primary palliative care, irrespective of the practice setting. For oncology nurses, more training in specialty palliative care and end-of-life care may also be helpful.
And what are some additional resources, whether for patients or for providers who want to learn more about palliative radiation therapy?
ONS for sure. So ONS has got a lot of different resources related to palliative care and palliative radiation therapy. Again, as I mentioned earlier, the Serious Illness Conversation Guide can be really helpful for having those difficult discussions with patients and their loved ones. Virtual Hospice is an organization in Canada that provides a number of very good resources. And again, even though the title is called Virtual Hospice, it's not just exclusively related to hospice or end-of-life care only. The American Society of Clinical Oncology and Multinational Association of Supportive Care and Cancer also offer some really great resources for patients, family caregivers, and clinicians. And then getpalliativecare.org is another organization that provides lots of great educational resources for patients and providers.
Reanne, this has been great. Again, thank you so much for being with me today and for your expertise. And you can really hear your passion for this area and for educating patients on why this is so helpful, as well as, having the nurses understand this better. And we're excited to have you speak at Congress. Do you have any final comments for us?
Yeah, not to sound like a broken record, but I think the most important consideration when thinking about palliative radiation therapy is to really think about the patient's goals and wishes. And, there'll never be a one-size-fits-all approach to palliative radiation therapy or palliative care in general. But to think about, what's the patient hoping to get out of treatment? Is their goal to live longer, to live better? And thinking about those trade-offs, what would be something that they would consider unacceptable? So, another good friend of mine recently underwent treatment for progressive glioblastoma. He was told that one possible risk of treatment was that he may lose his speech and his ability to read. And to him, these risks were acceptable. He's got young kids and he wanted to pursue any treatment option that might help him to live longer and spend more time with his family and loved ones. But again, those risks were really carefully explained to him going into treatment. And, I think his treatment team was very, very honest about the potential risks and, the treatment expectations as well. So thinking about Congress, I'm excited. And there are a number of sessions on radiation therapy and also on palliative care. And I think having conversations like this really help to normalize palliative care and get the word out. So thank you for doing this podcast. And thanks to all of you who are listening or who will listen in the future.
Thank you, Reanne. We really appreciate you being on with us today.
Thanks, Stephanie.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you downloaded your podcast. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org. The ideas and opinions shared in this episode represent those of the guests and not necessarily ONS.